everyone, just to say that we're going to be starting very shortly. We're just waiting for Josephine to connect.
Okay, thanks.
Hello, that's it. Wait.
Hello, everybody.
Hello. Hi, Josephine.
Hi, Josephine. Yeah. Okay, sorry, we're in another, with the circle. Sorry, we are the ones who delayed, but since we have about 29 participants, let's start. Angeline, which country is starting?
We're going to be starting with Cameroon.
Okay. First of all, thanks so much, colleagues, for really responding so quickly to this invitation. As you all know, the tradition for the GNC is that when we have a new humanitarian emergency, we would normally link with the country office colleagues or the coordinators to give us a short update in terms of the situation, the response, the gap, the challenges, and also key asks from us at the global level. So this time around, we got on board Cameroon, the response which is in the southwestern part and northwestern part of Cameroon. And Rogers, who is our cluster coordinator there, would be presenting, and then we also would shortly after that, I think we'll take both presentations together. The second one is from Venezuela, the UNICEF country office there. We have a colleague online, supported, I think, by Stefano Fedali, who you all know is the regional nutrition advisor for that region. So with that, without delaying any further, what we'll do is we'll take both presentations, one after the other, and then after that we open up for questions, clarifications. So with that, I hand over to Roger.
Yeah, thank you very much, Josephine, for the introduction, and good morning and good afternoon, everyone.
Hello.
Hello.
Hi,
Hello?
Rogers. Yeah,
Hi
we can
there.
hear you.
Morning. Yeah, I will do the morning. Yeah, I'll do the presentation for Cameroon, and if you see the map there, the map on your screen shows the. I'm not sure if you're able to see the map, but it shows the two regions in Cameroon, the Anglophone regions that is affected by the current crisis at the moment, and the blue bubbles shows the number of displaced persons as of January, and in both the two regions. Thank you. Maybe good the next slide. Yeah, since As some of you might be aware, since 2017, there's been a lot of tension in the Anglophone region of Cameroon, that is the northwest and the southwest, and it has now escalated into a situation that has resulted to armed conflict, where we have non-state armed groups and fighting non-state armed groups in conflict with the government military forces, and this has resulted to significant loss of life, destruction of property, and breakdown of health and education services. And in these cases, we have been able to see that the health system has also been attacked. There's been targeted attack towards the health infrastructure. So far, from the recent data, we have about 4 million people have been affected, and as of January, that is 437,000 people have fled their homes. Either they are living in the bushes, and some are also living within the IDP camps. With regards to the humanitarian aid, in most cases, actually, the humanitarian aid is being provided by the local NGO, which in most cases it's a small scale. It is a small scale, and this is because the local NGO have the knowledge of the area, and also they are accepted within the community, and also the warring parties, and access is also limited. The other thing also to mention. The other thing also to bring out with this local NGO, we also have, in terms of the awareness of humanitarian principles, is very limited, and this is something that has been addressed in different forums, and agencies are trying to help the partners build on this. In terms of the nutrition situation, the two regions historically have been having low levels of global acute malnutrition, and in terms of percentages, 1.5 in the northwest and 2.2% in the south. And this is based on the mix that was done in 2014. Also, in terms of IWCF, the breastfeeding rates have been very low. For the northwest is about 58%, that is the EBF, 58.3%, and for southwest region is 42.5%. In terms of recent data, as we have not been able to conduct a comprehensive nutrition assessment so that we can be able to capture the entire nutrition situation. However, the WFP, while they are conducting emergency food security assessment, they were able to integrate mark screening into the EFSA studies. And so far, the results have not been validated by the cluster, but indications are still there. It's a low gap, but there's still a major issue. Access even during the assessment was a major issue, and there could be a possibility of higher nutritional vulnerability, especially to areas that the team are not able to access, and other areas that are hard to reach within the two regions. And in terms of forecast of nutrition situation, probably what we are seeing, and this one is based on the underlying factors, if the actual are not addressed, in terms of the food security, there is reduced production because people have not been able to go to the farms due to the conflict, and also limited market access. And this one was also captured through the EFSA study that was just completed. And most of the households, especially in the southwest, are dependent on the markets, and there's a reduction in terms of access to markets due to the fear of attacks, and even the business community cannot bring the products to the market. In terms of health is one of the key sectors that has been really affected in this crisis, and there's limited access to service due to the closure of health facilities. Also, there's been attack of health staff, kidnapping, and in terms of disease surveillance, most of it it has collapsed. And also, there's a disruption in terms of the vaccination and immunization programs in the two regions. In terms of WASH, there was an assessment that was done by REACH that was looking at water sanitation and hygiene. That was done in December 2018, and actually results from the assessment indicate poor hygiene and sanitation, and also inadequate access to adequate and safe water for drinking. So these are some of the key issues that actually probably, if they're actually not addressed, timely, and also in terms of the coverage might put the nutrition situation of the population at, especially the vulnerable people, at risk. If they go to the next slide. In terms of the achievement per activity, what I'll be able to indicate is the nutrition cluster response plan for the two regions is being developed. But if you see the figures there, are based on the targets by the operational agencies that were able to set before the cluster was established. So in terms of the people in need, calculation will be determined based on the assessment that has been done, and at this particular time we'll be able to utilize, once the EFSA assessment has been validated, then we'll be able to utilize that. And for instance, if the access really improves, then we'll also advocate to be able to ensure that a comprehensive assessment is able to be conducted. So these targets were based on what key agencies had put actually in the OPS, and in this case is WFP and UNICEF who had come up with the targets. And in terms of the achievement so far, the monitoring framework has just been set through the support of the Global Nutrition Cluster, and probably now the reporting is now for those who are doing some sort of response, will be able to start reporting from the month of March. Also, in terms of also funding, in the funding, they have indicated 67% funding gap, and this is also based on what the key two agencies had put in the system. For instance, UNICEF had projected it for the response in the Northwest. Probably they were looking at it will cost $0.5 million US, and WFP through their through the management of moderate acute malnutrition and blanket supplementary feeding program, it will take $1 million USD. And if you look at the gap, you'll see 0.5 is actually represent what UNICEF had mentioned that they'll be able to cater for the response when it comes to IYCFE and the capacity building, and also the management of acute malnutrition, the SAM cases. In terms of the partners, still we have very few number of partners, and this one we are talking about the operational partners who have the potential of actually responding to nutrition, or they're already doing something. So far, the cluster system has already been set up, and we are having a participation around 15 to 20 members stroke partners. But in terms of those partners who can really implement the response, are 6. So if you look at if you look at the targets for SAM, that is to 2,100, that represents 70% of what was estimated before by the UNICEF. MAM, the moderate acute malnutrition, I'm talking of 2,500, and this one is mainly between 24 and 59 months, because the 6 to 23 months, they will be captured through the blanket supplementary feeding program. And for IYCFE, the target that was set initially was 20,000. But just to say, this one will be able to change based on when the cluster decides to develop, when the cluster will develop the rest of the plan based on the new findings. We go to the next cluster. Next slide. In terms of the key strategic nutrition priorities, we identified 5 key priorities that actually the cluster will have to ensure the cluster will have to prioritize. First is on the capacity development of existing local partners to set up CMAM programs. This includes identification, referral, and treatment, and also optimal infant and young child feeding in emergencies, nutrition assessment activity, and this will be based on the capacity mapping. Just to mention on this is because the phenomena, the area was the region where the crisis is happening. The NGOs that were there and the partners, the government, were more of developmental program. So in terms of the capacity, in terms of the knowledge on nutrition in emergency, is still very low, and this is why capacity building comes up as a top, as one thing that actually have to focus. The other priority is on provision of quality care and treatment, provision of quality care and treatment of acute malnutrition, especially to hard-to-reach areas. And this one includes scaling up of direct delivery nutrition intervention through RRM mechanism. At the moment, because most of the, not most, we have quite a number of affected populations that have been displaced and are in the bushes. And UNICEF at the moment, is engaging with partners within the local partners so that they can have a package, a RRM, a rapid response mechanism package in the world so that they can be able to reach the affected population. And in this package, we have WASH, child protection, health, and nutrition. And nutrition is also part of the package of the RRM. The other priority is prevention and protection of vulnerable groups against deterioration of nutrition status. That is through the blanket supplementary feeding program approach and infant and young child feeding in emergencies. So we'll also seek to strengthen nutrition cluster coordination, and the key priority now is actually we have to, as a cluster, we have to develop a nutrition cluster response plan, action plan, and finalize the capacity mapping, because we are having partners who actually have not finalized doing their capacity mapping for them to respond in the nutrition response. And also we're also prioritizing in engagement with other clusters, especially food security, health, and WASH, so that we can have an implementation that is integrated, looking at nutrition sensitive and responses in selected areas. In this, we have already started discussion with the food security to see how the food security and livelihood, to see how the livelihood intervention can be able to integrate nutrition action so that they can able to improve the nutrition outcomes. So far, we have not moved far, but the discussion have just started. The next slide. In terms of gaps in resources, maybe I'll start with the human resource. Due to the current insecurity and targeted attacks of the health workers and the health facilities, there is a shortage of health workers to implement nutrition services at the health center level, and also there is in terms of technical capacity, it's still very low. It's still very low for the partners to implement this intervention both at the facility and community level. And with this, we have started discussion with UNICEF and key partners to see how actually UNICEF how they can support this. But it's still something that is going on. Financial resources, in terms of the financial resources, in terms of the gaps, as already mentioned before, we are talking of about 33% funded, and this is mainly from what UNICEF had indicated in terms of addressing the needs of the severe acute malnutrition and IYCFE. But this one, just to highlight, this one is based on the old estimate that was done before the current assessment that was done. So this one is also likely to change in terms of the needs after the cluster has been able to come up with the people in need. In terms of supplies, for handling severe acute malnutrition, UNICEF has committed that they have adequate supplies, including the anthropometry and the RUTF and also the therapeutic mix. For WFP, at the moment, they've not been able to acquire supplies for the TSFP, for the targeted supplementary feeding program and the blanket supplementary feeding program. And probably this one might limit the scale up of the nutrition response. And from our discussion, probably this was because of the focus to address the food security as they continue looking for funds for the nutrition response. Because even for the food security, the coverage is still very low based on the information from the FSL, the Food Security and Livelihood Cluster. Okay. The next slide, please. The challenges with regards to achieving the strategic priority, access and acceptance is still a major issue in the entire humanitarian response. And this one does not only affect nutrition, but the entire humanitarian response, and that's the reason as to why there's a need actually for us to work together with the local partners. Insecurity is still going on as people feel, as there's a lot of fear, and there's also cases of banditry, and this is because the bandits are taking advantage of the situation where people might not be able to know whether they're non-state actors or the government forces. So it has created an opportunity where bandits are able to mount roadblocks and we have also been able to have cases of kidnaps. There's also displacement of communities into the bush, which makes it very difficult for various humanitarian actors to access the population there.
Roger,
yeah.
Can you conclude in the next 2 to 3 minutes so that we can have the second presentation, also have time for discussion? I know you only have one remaining slide, but just to let you know that if you could conclude within the next 2 to 3 minutes, that will be great.
Okay, sure. Thank you. The other issue is the partner technical capacity to respond, and as already mentioned, nutrition in emergency programming is a new area for majority of the potential partners, and also in terms of the tools. The national tools for nutrition are in the guidelines are not available in English, but it is now in the process of being translated from French to English. There's also lack of comprehensive data in terms of nutrition, and this could result to response planning to the planning of the response not reaching the most vulnerable locations and populations. And there is also lack of comprehensive picture of the needs, or the lack of a comprehensive picture of the needs and a stronger prioritization of nutrition response, hence hampering partners' fundraising efforts, because quite a number of partners have been able to pitch up proposals, but I think they've not been able to access funds for the programming. The last slides. In terms of the key asks from the Global Nutrition Cluster partners is, we have 3. There is a technical support for comprehensive nutrition assessment, particularly RNA, rapid nutrition assessment, methodologies for volatile areas. And this one is especially when the access improves, because now access is still an issue. Also, we also request for specialized technical capacity building support for local NGOs on specific thematic areas in nutrition, including CMAM and IWCFE. And this one, the focus is on local partners, to build the local partners because of the acceptance issue. Because even if an international partner comes in, the best approach is to work through the local partner. Support nutrition. We also require support from GNC to ensure that the nutrition cluster advocacy efforts is able to be raised higher, so that the risks in the response. Hello.
Yeah.
I mentioned about the advocacy, so that the nutrition needs are raised higher, so that you can also improve the fundraising efforts. Thank you.
Oh, okay, thanks so much, Roger. That has been so clear, and I think the fact that the presentation is there is really good. We'll try to share it later. But colleagues, if you can hold on to your comments, questions now. Angeline would upload the Venezuela presentation, and yeah, it's up. So who is presenting? The colleague from the Venezuela country office. So Stefano, go ahead, please. Thank you.
Thank you, Josephine. We are together. Zandra is the nutrition specialist in Venezuela. She will be presenting, but there is also with me Marc-André Prost from WFP, who is supporting UNICEF in Venezuela at the moment. And over to Zandra.
Okay. Hello, everyone.
Hello, please go ahead. Yeah.
Thank you. Okay, I'm going to talk with nutrition response in Venezuela. Currently, we have 8 prioritized states from our interventions. Next, and we have 3 field offices in 3 of them states. What is the current situation? From 2018, political and economic crisis led to hyperinflation, massive immigration affected the situation in terms of access and quality of social services. This situation continued and worsened in 2019 because we have a significant deterioration of the political economic situation. Actually, in the last week, we have experimented permanent blackouts and deterioration of the communication, the lack of access of water, health services is collapsing, and obviously we have mortality increasing in the children, born children, and obviously in the population. Unfortunately, we don't have official and up-to-date information about the real situation, and we have some information about living condition national survey data collected between 2014 and 2017, and the prevalence registered for this survey was 4% of global acute malnutrition and 22% of stunting. We have recent but not representative information about local NGOs collected in educational centers in some states, like Fe Alegria, and they reported 3.3% of acute malnutrition. And Caritas is a local NGO, probably the with most or the high operation in the states, and they reported 17.2% of acute malnutrition. It's important to remark this prevalence is so high, and probably because they have the operation in the most vulnerable population, and obviously they focus in this kind of people, and probably this percentage is not representative for the population under 5. We have a problem with the diet of the population. Probably we have a availability of food, but in terms of calories, but very, very poor in terms of micronutrients. And we are thinking the problem is the micronutrient deficiencies. Next, please. Okay, this is targets and popular needs in terms of different activities. We have people in need already 692,000 people, and we are trying to expect to increase our operation. In the last months, we are serious security restrictions to implement and to reinforce with the local implementing partners about the nutritional interventions. Unfortunately, we have noticed the local implementing parties don't have the capacity in terms of the nutritional interventions is they are focusing in the food interventions, and we need to strengthen this kind of capacities. We estimate the attention to several acute malnutrition in 914 children, and in attention from the 2,743 children with MAM. It's micronutrient supplementation in already 484,000 children. And it's important to us to reinforce the strategies in infant and adult child feeding in emergencies and deworming. As I told you, our targets we are working in that jointly with OCHA and M&E unit, because the lack of official and update information is complicated to do this kind of estimations. The people reach is low because we have security restrictions too, and obviously the implementing partners too, in terms of the implement actively the nutrition interventions. Next. What is the strategy in nutrition priorities? We need to expand and to strengthen the capacity of social society and organizations to respond in terms of nutrition needs. Is a kind of basic things, but it's necessary because we don't have or the institutions don't have material printed equipment and capacities to nutritional diagnosis, and obviously these kind of things affect the attention or interventions. They need anthropometric screening, micronutrient supplementation, and management of acute malnutrition in inpatient or outpatient scenarios. Conduct rapid nutrition assessments because we need to information about nutritional status, food security, and we think smart methodology in at least 5 prioritized states is good to start. Provide training on nutrition cluster coordination, nutrition in emergencies, including IYCF in emergencies, nutrition sensitive programming, and obviously monitoring and evaluation of emergency interventions according to local conditions. And we need advocacy to donors with regards to large quantities of therapeutic foods arriving in the Colombian border with Venezuela, specifically in Cucuta, where are a lot of there are a lot tons of this kind of supplies, and they have the high risk to distribute in blankets. Next. In terms of gaps, we notice we have gaps in terms of human resources. Actually, we don't have, or we are not participated in different trainings in terms of smart methodology, nutrition in emergencies, monitoring strategies, because Venezuela, UNICEF Venezuela country offices has emerging because this country is thinking in the development and not in emergency issues. Financial resources, we are thinking in between 7 and 10 million, because we need to expand our interventions in the other states, because we have only 8, need to expand with other states where we have people in need. And in terms of supplies, we need LNS and Q to focus and prevent the undernutrition, multiple micronutrients, iron, folic acid, because it's important to treat the anemia and other micronutrient deficiencies, micronutrient tabs, and probably rules LNS for pregnant women. And anthropometric anemia screening equipment, because the equipment available is so old and doesn't work. And as you told printed material and technology information in terms of growth charts and devices to improve the anthropometric classification and improve the nutritional diagnosis to conduct better conduct the interventions depends on the nutritional diagnosis. Next. What is our challenge? In general, the volatile security situation. We are severe restrictions, and obviously we are so we have some complication in the operations, but we are trying to improve, and we are trying to work in this situation. The high devaluation is the local currency is very bottlenecks because the local money is in constant devaluation, and obviously the money is very insufficient to pay the different operational aspects. Strengthen the technical assistance to local implementing partners. Actually, we don't have many implementing partners. They have some restrictions to stay in this country, and obviously it's complicated. For example, ACF don't have the permission to stay in Venezuela. Sector specific, lack of the up-to-date representative nutrition assessment about the situation of children under 5. Venezuela has not adopted WHO growth standards, and obviously these are kind of a confusion about the nutritional classification, anthropometric classification on obviously the results about the nutritional situation, and the lack of the protocols of guidance for nutrition interventions and integrated management of acute malnutrition, low capacities of implementing partners in terms of nutrition interventions in emergency especially, and weak monitoring strategies in the field to identify gaps and the advances in the programs. Next. And 3 key asks to GNC is training support on nutritional emergencies and key nutritional intervention in protracted context. Probably this is the most important challenge, because in Venezuela there are institutions, they are staff with some capacities, but we need to work jointly with them. We need their approbation of our interventions, and it's probably bottlenecks to implement and to expand the implementation, but we need to work with them. Support to develop, promote the standards, and develop capacity for local implementing partners, including social mobilization for interventions, nutrition interventions. We have to strengthen the local partners and social organizations to improve and to ensure our objectives. And finally, support the implement nutrition sector coordination activities and nutrition advocacy in political polarized context, as is very, very hard in Venezuela. Over. Thank you.
Yeah, thanks so much, Sandra. That was so clear, and we really appreciate it. Now, I will ask we are left with almost 18 minutes to ask questions and have a discussion, but I think in terms of the key asks to us at global level, they are quite clear, and we could then maybe have a discussion on how best to support the two countries in those key asks. But before we go to that, can I open it up to suggestions or questions or addition? Stefano, you are in country. I don't know whether you and the WAP colleagues want to add something before we open it up to the GNC partners.
Hi, Josephine. Yes, if I may, and then I'll invite also Mark to add his comments. Just wanted to mention that there is an unusual structure in relation to nutrition in the country. There are some activities that are led by the Ministry of Health, and traditionally the Ministry of Health has led initiatives related primarily to antenatal, maternal care, postnatal, and in relation to infant and child feeding. While we also have the Instituto Nacional de Nutrición, the National Institute for Nutrition, which has traditionally taken care of supplementary and therapeutic feeding and many other issues related to food standards, food assistance, and so on. So it's really important to ensure that there is we support the collaboration and initiatives that combine the effort of both these institutions, and also, you know, they cover a large proportion of the initiatives implemented in the country for nutrition, also because there are very few NGOs, and the capacity of the NGOs present is very limited. There is Sandra has facilitated discussions, and she has only been here for less than 2 months, but she has already initiated interesting discussions to get an agreement between the Ministry of Health and the National Institute for Nutrition to update their protocols. Now, obviously, the political situation is a bit complicated, so we are not sure whether an official protocol can be done very rapidly, but we are also proposing perhaps an acceleration of the process with a temporary protocol to better respond to the crisis, because clearly it's very difficult to introduce even supplies and approaches if the standards are so outdated. And so we are in these discussions are ongoing, and it is likely that we are going to have a simplified approach which combines care for both mom and son in the same facility, and with we are also trying to limit the type of supplies that we have in the country, so that to facilitate this process and the expansion, the rapid expansion. And also, it's quite important that Sandra has mentioned it, but the last week has, beside the chronic challenges that we have in the country, the last week has been particularly bad because complete nationwide lack of electricity, which has not only affected light but also affected the water pumping, has affected payment for essential service because there is very little cash around, and most payments, most basic payments are made with electronic payments, which were, most of the countries been unable to do so even to buy food, to buy medicines for the last week. Today there is a little bit of improvement, and also the fact that we are able to connect at all today is a great achievement, and we hope that the situation will stabilize in the next few days, but the vulnerability remains. Also, this affected a lot the capacity to have water and sanitation, and the risk of water-based infections is rapidly increasing. There was a big risk before, but now it's deteriorating rapidly. I think I'll stay here, and unless if Mark wants to add some other components. And hold on a second.
Yeah, sorry, just a quick comment on on some of the data that Sandra presented. It's not clear what is happening, but what is clear is that there's been a severe deterioration of the situation in the past couple of years. What is happening now is going to make things even worse. So there's no doubt that there is a need to increase a lot the coverage of the nutrient response right now, with an emphasis on prevention, and there is no good systems available to do that. The health system is in tatter. The parallel system put in place by the National Institute of Nutrition is not working, and is very limited in terms of size and scope. And the school sector is also heavily impacted. So it's complicated to think about how to do it. However, what is clear is that there is going to be a huge need for training and for capacitation of the resources that are left in the country. So this is the first thing I wanted to highlight, is that there will be a need for a very significant training plan for nutrition in the country. The other thing I want to highlight is that there is obviously a big polarization in the country right now, with one part of the country saying the government is not doing anything. The private sector is already moving into some sort of charity work. There has been donation of breast milk substitute. So I think it's important to think now about how to strengthen the monitoring of the application of the code in the country. Over.
Okay, thanks so much for that. I think before I maybe open up, there were a few comments online already. One is actually from Maya, linked to what Stefano said around the protocol development. And she was asking what is the engagement of MOH in developing the protocols and whether they are willing or not. Stefano, you touched a little bit on that, but if maybe you could just say whether they are, you did say it will have to be, like this is simplified given the capacity issue, but also the sensitivities. But if you could highlight that a little bit. She also asked, both Sandra and yourself talked about the local capacity, well, the local NGOs not having capacity, but what levels of NGO partners are we looking at? Is it big? Are there many local NGOs through which we can work, given the fact that there could be some restriction from the international NGOs? And then there is also a question about the screening, how the screening could be managed. And there's a mention of Caritas, but do they have the technical knowledge to do this? Or is there any activity to support the general population affected by malnutrition and so on? So, just take note of those questions, and then let's take one or so additional comments or questions from the participants first. Please feel free also to go back to the presentation made on Cameroon, the one Roger made. Anybody would like to come in?
Josephine,
Yes.
Hi, it's Caroline. Could I just ask a clarification question? Because Rogers, I understood that that you'd said that there was a targeted supplementary feeding and a blanket feeding, but then later on in your presentation, I understood that there was a problem with supplies for both of these programs. So I was just a little bit confused as to whether there was a program or whether there isn't one, or whether it's planned and awaiting resources. So if you could clarify that, please.
Okay, thanks, Caroline. One additional comment so that we can have both colleagues responding one after the other. Any additional question or comment? Anybody online wanting to ask a question now? Okay, why don't we ask Rogers to respond to Caroline's question of whether there are existing Sam and Mom program, and if yes, then and also the fact that the supply for those program is a problem. So if you can clarify, Rogers, over to you.
Okay, thank you very much, Caroline and Josephine. Just for the blanket supplementary and targeted supplementary feeding program, these are programs that have been planned, and the WFP had indicated it will support this program. And in terms of whether supplies are there, not yet. According to WFP, they have not been able to get resources for that. So this is something that was planned before, I think, for the 2019 response in the Northwest and Southwest, even before the cluster was established. Thank you. Over.
Yeah, but Rogers, can you also clarify, for you had targets and you had achievements. Was that for the response or the activities which were already ongoing in that part of the region? Because you said there was some ongoing response, but now with the emergency, there's additional need, and then that was what you articulated in your strategy. So if you can explain whether currently is there an ongoing nutrition response? And then two is, but is that based on the old program, and now you are in the process of developing a humanitarian response plan, which then has those strategic priorities? So if you can differentiate between the two, that will be great.
Yeah. Okay. Thank you very much, Josephine. For the targets that were there, the targets that have been able to provide are based on the operational targets that were being provided by UNICEF and WFP. That was for the planning for the Northwest and the Southwest response in Cameroon. And in terms of any response that was going on, there is limited, in terms of the nutrition implementation, there is limited response, and this one is mainly on the screening and referral for treatment. And this one is on a small scale because UNICEF late last year they engaged with Action Against Hunger, and they provided them with supplies for the management of of severe acute malnutrition, whereby when they do the screen, they're able to refer. But that one is at a small scale, not at a very, very large scale. In terms of the second question was on the response plan. The strategic priorities, this is what we have been able to identify from the meetings that I've been able to have with potential bilateral partners, and also from other clusters. So these are the priorities that we have identified as a cluster that we need to
focus on this year.
Yeah.
Okay.
Yeah.
All right. Stefano, the question about the MOH interest in supporting protocol development, but also the availability of partners on the ground. If you could take that, or Zandra could take that.
Okay. Yes. Actually, the MOH is interested in our support, but it's important to remark some kind of resistance. Because they have some challenges in terms of change of growth standards and the strength capacities. But we are the advocacy and the work with them is ongoing. And we expect the results probably in 1 or 2 months with temporary protocol to rapid nutritional interventions. In terms of the partners, actually the most coverage we have with Caritas. But as Mark say to you, it's a kind of charity of organization, and we have to strengthen all of their capacities. And we have SHISP and Fe Alegría, and probably ACF. We if they have the permissions, government permissions, and we are working with government, local governments in terms of health institutions in local level to add the nutrition interventions in the ambulatory or community health primary services.
Okay.
We have some kind of opportunities in the schools. They are working in the initial education, and probably they are calling the families, and we have opportunities to intervene in children under 5 and pregnant and lactating women.
Okay.
Can I just something like that? At the community level, we're exploring different opportunities, and there is already quite a lot of work ongoing for scaling up the coverage, at least in the 8 prioritized states. These are primarily through ambulatory health facilities and engagement of community networks, through indigenous groups, through group of mothers, support groups, through pre-existing volunteer networks, but also using schools as a platform for reaching out to children and mothers in the community. So we're trying to, depending on the opportunities in different states, maximize this outreach to directly engage the communities, both to define the issues affecting them and also to maximize the opportunities for locally available solutions. And so there are, at the moment, there are several initiatives ongoing which are rapidly going forward. But again, the situation is very volatile, so everything can be set back You know, 1 week of total electricity cut out can set us back several months. So, and the overall political situation is constantly evolving. So we really need to be very flexible in maximizing the opportunities and see how better we respond to the ever-changing needs. Over.
Yeah. Okay. The other question, which I guess you partly responded to, was about the fact that since the nutrition crisis would possibly affect the general population, how do you intend to organize the screening? Because the data that was provided is from Caritas, and also you did talk about the technical capacity issues. So how do you intend to do that, given the sensitivity and all that?
Well, we have the Ministry of Health is asking for our support, and they are pretty, they are keen to strengthen their capacity to both identify and care for children with acute malnutrition. So but once we have addressed the protocol component for care, I think that there is going to be much more work done at the lower level of health facilities in the health system. Also, as I said, for example, Caritas is using community networks to identify children at risk. These screenings are not always active screening, but they are systematic in municipal areas with the highest vulnerability, and so these screenings then are reported for care within the Caritas system. Also, we think that there are some important opportunities to use schools for engaging, to convene activities, both of school children. Here, the primary schools started at 3 years of age. So there are quite a few children under 5, even in primary schools. But also, we understand that schools and teachers play a very strong role in the community. Yes, it's true that there have been dropouts. Apparently, only 60% of children go to school. But most schools remain open, and they still have the ability, apparently, to call the communities, call mothers to bring their children to school and use the schools as a platform for screening, and then referral to the services that will provide care when a child is found with malnutrition. So this is ongoing work, and I think if we have some more stability in terms of if the situation does not deteriorate further in terms of electricity and insecurity, then we expect to have quite a lot of growth in the coming month. The capacity as well of the existing partners within UNICEF and of other key stakeholders is also increasing. We are also faced, though, with a drastic reduction in capacity in the Ministry of Health. A lot of staff have left, so we have to play. We have to keep monitoring the situation and use the available resources. It's very difficult to do accurate planning, but there are some positive signs. Over.
Okay. Thanks so much, Stefano, for those additional input. We actually on top of the hour, but I thought we could also ask the partners, because there are those key asks, so to see whether online there are already partners working in those 2 countries who could maybe come up with some suggestions. But normally with the key asks, we also would have to reach out to the partners bilaterally, kind of to find out whether there are partners who are interested in providing this support. But before I do that, is there any other question online? Anybody would like to seek more clarification on the presentation or the response or the strategy that they have put forward in terms of what they are going to do to respond to the crisis? No? All right. Maybe we start with with the Venezuela one, because it's right in front of us, but clearly the key ask is around support for training in nutrition in emergency and the development of the guidance and the standards, and finally also around sector coordination and advocacy. From the global nutrition cluster side, if you are clear to us in terms of the cluster approach, what kind of orientation you need and so on, we will be able to reach out to you to see how best we can support you in that. But the first two, which is the capacity building and then also the protocol development, we do have a number of partners at global level who can provide that, but at the moment it's really need based. It's based on the individual partners. So for Venezuela, if I can open it up, are there any of the partners online who are planning to provide that kind of support, or should we reach out to you bilaterally for that? Of course, that will include the Tech RRT colleagues if they're online, and also Ruth from the UNICEF side, and any other partner who was in the past supporting assessment. Or
sorry.
yeah.
Sorry, I just wanted to make a clarification. I think that we are in the process of recruiting some consultants that have experience in strengthening CMAM in Colombia. Okay. And with these consultants, we hope that to cover most of the training needs in the Ministry of Health. But I think we also already have in Latin America and the Caribbean, we have a couple of 2-3 examples of simplified protocols that were used in emergency settings in Colombia, in Peru, and Ecuador, which we hope to have at least as a temporary measure while we work on. So the question of the support from the cluster is going to be primarily in the revision of these documents and guidance, ongoing guidance, as the process develops. Okay. Capacity building we may at the moment, and it may require some additional capacity, for example, in ensuring the adoption and diffusion of the baby-friendly hospital initiatives. And also we have, you're aware that there was a request for the identification of someone that could support the sectoral coordination effort that is ongoing now, not only at the national level, but also there are some good opportunities to strengthen sectoral coordination at the subnational level, at the state level. So we are still seeking an international nutrition specialist, which can help with the request for such capacity in sectoral coordination. Okay. Otherwise, there are ongoing initiatives which I think would hope that will be sufficient to cover at least the needs in the next few months. Over to you.
Okay, no, that's very good to know. But in terms of the sector coordination, as even when you have one person, if you are going to decentralize and strengthen subnational level, there'll still be a need to support you in that. And we are in the process of simplifying the 5-day training to just 2 to 3 days for subnational level colleagues, and that of course will need to be translated in Spanish. But let me just let us know what kind of support is needed, and we are here to help around the coordination aspect. It appears also from the training and also the protocol development, you already have some capacity in the pipeline. And if I get it right, what you really need is more support in reviewing those guidance, and that I think, I don't know whether Ruth is still online. We already have the GTM. We are trying to organize ourselves better, but I think we'll be able to support you in that. Andy, I thought I had you. Do you want to say something?
No, that I'm here. Stefano, I've already sent you an email, maybe a little bit premature, but if there are any ways we can support, we can look at it. And same, actually, Roger, for Cameroon.
Okay. Okay, on Cameroon, any other comment? Can you, Angeline, is it possible to quickly put up the Cameroon key asks? But I think they are in similar line. Yeah. So again, the Cameroon one is really more technical support for comprehensive nutrition assessment, especially the rapid methodology, which can suit the volatile situation. And then it's capacity building on those two programmatic areas. And then the last one is the nutrition cluster advocacy efforts. So the latter, the last one, based on our advocacy strategy, but toolkit, Roger, we should be able to work with you to support you in that. While for the technical support in assessment, but also the specialized support, capacity building of partners, again, if you could clearly say who are these partners, how many they are, what kind of, profile they have, we would then be able to maybe table it with the tech RRT to see what is the best way to provide that support. Unless there's somebody online who wants to come up and say, yeah, we are willing to come over to support. That is also welcomed. Anybody?
Olivia from ACF?
Yes, yeah.
In fact, we submitted a proposition on capacity building, but we did not get any fund for it. So we are still looking for donors. So we are interested in the two first points: the technical support and technical capacity. The main problem faced in these two regions of North and Southwest is really security and access to beneficiaries, to children even. We did an assessment, and we could only measure the MUAC and check edema to children that have been brought to us. It's impossible to go house by house and to have an assessment without bias. It's very difficult to. So we are still thinking about new assessments and trying to make in a different way. And but we are waiting for security validation from our security guy.
Okay. No, thanks so much for that, Olivia. Olivia, what you're saying is there's the proposal, and if it were funded, then you could provide the capacity building support as well as the one around assessment, but security remains a big problem. And also the capacity of the local partners. Maybe outside this, Roger, what we could do is to look at, you did say it's better to work through the local NGOs, but I mean, you can only build capacity when there's some basics. So it would be good to have a discussion of like, what is the bare minimum? What can they do? Because if they haven't really been engaged in this kind of program, the capacity building will require further assessment of what is there, which I guess you are addressing through the capacity mapping, but maybe we would try to organize a side discussion, Roger, between you and ACF. But Olivia, do you have somebody on the ground already in Northeast? You have somebody in country already, right?
We are looking for someone, but we have already a national staff who has been working for us with during the emergency in the east part of the country, so he has knowledge on nutrition. But we are looking for a nutritionist or health and nutrition expert to go to this part of the country. But we have already a field manager there.
Yeah, no, I think it's good you raised this because we could also highlight this with the UNICEF colleagues on the ground, so that whenever they talk to a donor, the ACF proposal could also be highlighted as one of the key proposal that could support the collective response. But would Roger, you are still on R&R. Can we maybe make a separate outreach to you to see whether we can have a better understanding on how the capacity building or the assessment could be further arranged? Can we do that after you come back?
Yeah. That one, it's possible. We can able to have a discussion on that, and it will be one of my key priority.
Okay. All right, colleagues, I know we are 15 minutes over the time we had allocated for this. It's normally 1 hour. Any comments from anybody? If there, yeah, hello, yes, yeah.
Yeah, I'm Mira. I'm the medical officer for Medicine Sans Frontiers, Belgium.
Okay.
And yeah, I mean, it would be really good to have more like coordination at the ground level in Venezuela itself, because I'm working for in Belgium, and yeah, we have an MOU with the Ministry of Health, but this is more on the malaria program. We are supporting the malaria program in Bolivar State. And yeah, it's limited in what we can do, but so far in my last visit last November, because we don't really collect data systematically regarding nutrition, because we're only supporting like the malaria program. And we recently had a MOU, official MOU, and it's a good sign, although things really are unpredictable and can change anytime. But I think it's a good way. What good way is to one good thing that you already mentioned about is supporting the local partners, because I think this is yeah, we've been kind of doing that also. And I think this is the only I think the most brilliant way, because it's really sensitive as for us to do certain things. But so far, eyeballing the people in that area, like the children, we don't really see this acute malnutrition kind of even adults or children in so far this November. And yeah, I think it would be, I will definitely inform the people on ground how to get coordinated with the local partners, and also and also other partners, UNICEF on ground, and we'll see also the potential on how to partner with the Ministry of Health, because I think they reach a point that like they really need help, and I think there is some willingness. So we will see on the nutrition side also, if that's the case.
Yeah.
I will definitely inform the people on ground.
Okay. Yeah.
Thank you.
Okay. Thanks a lot. We started with 40 people. Now 12 have dropped. We still have 28, so we somehow need to wrap up. Stefano, just based on what Maya, is it Mira just said? Oh,
yes.
Yeah. I really think maybe it would be better that we will make a special outreach to you and Zandra on the plans you have for strengthening the subnational level coordination, and to see, what it is as soon as this focal point comes on board, how we can support that, because clearly it appears that once we have the subnational level structure figured out, it will facilitate a number of things. So it would be great if that could be organized bilaterally between us. There was something that Zandra mentioned, which I think was not highlighted as a key challenge, and I don't know whether the donor colleagues who are with us are still online, but the influx of ready-to-use therapeutic food, but also ready-to-use infant formula. I really think we learned a lot of lessons from the Haiti response. So much of the ready-to-use infant formula was brought in without proper estimation of what the need is, and we ended up really in a big trouble in terms of how to dispose of it. Similarly, even for the ready-to-use therapeutic food. So I think it will really be important that we liaise with the colleagues on the ground on this, so that the donors or the partners who are bringing in this supply really liaise closely with the colleagues, so that is based on the need on the ground. And if Zandra, if there is anything in particular you want me to write or to communicate to the partners at global level on that, I can do that. But I'll reach out to you in terms of what are the quantities and what are the concerns around that, and how we can then frame that advocacy. Finally, I would like to mention that the CDC are saying that they can provide distance support, which means that for both Venezuela but also Cameroon, but specifically I think for Venezuela, if you start the revision of the development of this the guidance, and you want somebody to kind of take a look at, I think we have colleagues at global level, both through the Tech RRT, but also CDC, who can provide that remote support. With that, I would like to end, because we have lost about 16 people. We started with 40 and now we have 24, so it is an indication that we need to stop. I would like to thank both Roger and Zandra for really putting all this together at a very short notice. We do organize these calls to raise awareness on the situation, but also to, as a fundraising, tool to partners to be aware of the gap that is in country and what support is needed. We would, as I said, reach out to you on those specific issues, while we would then decide whether there would be a need to, again, maybe after a month or so, have a similar follow-up just to see where things are. But that we'll do in consultation with you, with the both countries. So just to say thanks so much for your time, Stefano, and the other Mark, the other colleague, and also I would like to also thank all the participants. We got a very high response rate, as you can see. Many partners really wanted to know what's happening. We had about 40 people who called in, and that's a commendable number. We'll follow up on some of those action points as already discussed. So thanks a lot, and thanks to Angeline, who has been the one working, liaising with the two country colleagues. So thank you so much, and bye-bye for now.
Thank you.
Thank you.
Thanks. Bye.
Bye-bye.
Thank you. Bye.